Hello, all my friends in the dental world. This is your old pal, Jeff Horowitz with Dentist in the Know, and welcome to Humpday Happy Hour. This is your backstage pass for current trends, politics, and education in the dental world. It is live, as always, and it is over a lovely glass of Pinot Gris. Having trouble speaking, and I've only gotten one sip into my glass. It's over a great glass of Pinot Grigio tonight. I am with some of my best friends in the world and incredible colleagues, Dr. Chad Duplantis and Dr. Jennifer Bell. You know that we are all practicing dentists, we are all educators, and we're all business owners. And our job is to bring all of you in the know. So, my friends, I was really excited when I was talking to you before the show because, well, two reasons. One, a topic that I've been talking about lately, and had no idea who our guest was this week until a few days ago, and just so happens that our guest tonight will be talking about a topic that I've been kind of ranting about, which is evidence-based dentistry and how so many kind of cling to this concept of evidence-based dentistry, but many don't really understand the biases and the protocols and some of the concerns with some of the evidence that's actually out there and some of the literature that's out there, and the fact that many people tend to read summaries and don't necessarily look at what makes up the study. So Dr. Dave Leader from Tufts University is with us tonight, and I'm really excited about that. But here's the other thing I was talking about, and then I might actually let you two say a word. I watched the coolest Netflix documentary last night. It was called The Bleeding Edge. And what it talked about was medical devices. And so this had a lot of applicability. They didn't talk about anything dental, but it had a lot of applicability to us. And it talked about the FDA and the process of getting medical devices approved and how that is a much easier process than what the pharmaceutical side has to go through, and that there are a lot of loopholes there, and not necessarily that we need to have more legislature, but if the FDA's role is truly to watch out for the health of the American people, that maybe some of these policies need to get looked at. But I would advise anybody in the medical field to watch this because it was really cool. Well, listen, we're a little behind here. So JB got some news for us
Yes,
because we have an
absolutely.
amazing guest tonight that
Yes,
I'm
we
really
need to get to
excited
it.
for. Yep.
All right. Well, let's go ahead and fast forward into some news. So, first off, we talked a lot about medical loss ratio. There's actually several other states that have medical loss ratio coming up soon. If you're not familiar with the term, what that means is that insurance companies are required to spend a certain percentage of their profits towards patient reimbursements, education, direct patient care. Massachusetts gained a ton of notoriety in 2022 with passing their medical loss ratio bill. And several states are kind of falling in line with that. So we're going to see a lot more activity in that in 2023. But as with all good things, there must be some tides to deal with. And so just this week, Guardian Insurance Company released a notification. They notified 1,500 small employers that they would be dropping their dental coverage as soon as the law goes into effect. These are employers that have 25 employees or less, citing that it would be no longer profitable for them to service those employees and employer with their plan, given the MLR. So, I don't know how all this is going to shake out. I do think states that have this coming up should certainly be looking at what is the cascading events that are happening in Massachusetts after passing the bill. If they could preempt some of these notifications and changes, that might behoove them to at least be watching and reviewing, because we're starting to see some of the unintended consequences of that law. In addition, another friend of ours in the New England Northeast area, New York, has legislation that has just come forward to approve dental health aid therapists in their state. Here was an interesting statistic I was not aware of. So, of the total population in New York, which is apparently around 18 million, 9 million of those individuals are on some type of government subsidy program for their dental health benefits or medical benefits. And they're having a very difficult time keeping providers in those programs due to low reimbursement rates, and also just challenges with patient servicing. So, the response from the legislature is to move forward with a mid-level provider to be able to provide care to that patient population of 9 million individuals who need access to care. It was interesting in the article that they cited that they would face great resistance from the American Dental Association, but are trying to pattern the program after other states like Minnesota that brought it into existence a few years ago to help solve some of their access to care issues. So we'll certainly be watching that very closely. If you happen to be participating in any type of telemed services in your dental practice, where you do consults, communication, et cetera, with your patients and provide prescriptions through the telemed service, there is an open listening session for those through the DEA to discuss the access to opioid prescriptions through telemedicine. That open listening session is happening on September 12th and 13th. That will be at the DEA headquarters. There is some additional information if you want to go to the DEA website to find out more information. But if you do happen to be providing prescriptions through telemed for opioids, that certainly may be something you want to pay attention to better understand where this may be moving and what challenges may be coming from that. And lastly, as I'd mentioned last week, with the HPI statistics, we've seen quite a bit of change in both the overhead expenses and profitability of the practice. And Dr. Bicuspid actually ran a similar study over the last couple of weeks. They surveyed a conglomerate of individuals, which they do yearly to sort of garner information about salaries and profitability and just the overall business of dentistry. And they too also cited a pretty significant drop in doctor salary. It seems to have predominantly hit the solo private practitioner, but also some decrease in the group private practitioners. So those who are not owned by DSOs. Interestingly enough, DSO doctors saw an increase in salary for year over year from 22 to 23. So the tides are turning. It does appear that the data is starting to justify the way that many of us feel in the marketplace. And if you're a private practitioner wondering why bills are a little bit more difficult in 2023, I think the data certainly is telling the full story. And with that, that's the news.
So would love if you would introduce him for us tonight.
Great. Well, as we always do, we like to make this an informal discussion with individuals in our community. So I happen to be on a couple Facebook groups, goofing around and just sort of reading comments. And our guest tonight, Dr. Leader, happened to be responding to a comment and was really pushing on the envelope of evidence-based dentistry. And as Jeff sort of opened up the conversation, I thought, this is a topic that number one, we don't talk enough about. And I don't know that we have enough individuals out there willing to peel back the layers on this to say, what's really going on with how we practice as private practitioners. What information are we using to make justified decisions in how we take care of patients? So I reached out to Dave and I was like, would you be willing to come on and chat with us a little bit and share some of your expertise, because he's lecturing on this topic as well. And he was very, very gracious to spend a little bit of time with us and share a little bit about his story and also his passion in this particular area. And then hopefully some practical advice for our practitioners out there and how that they can look at journal articles and look at data that comes in the mail every day, and not every day, but once a month. And, like they're consuming a lot of this information, but how did they discern what's going to change how they practice in dentistry? So with that, Dave, thanks so much for being with us this evening.
Thank you so much for inviting me. And inviting me to talk about one of my favorite subjects. And next time, let's talk about question 2. And
Yes.
Because I'm very involved with that also.
Awesome. Because there are several states that have this up for consideration in 23, and I think also in 24. So this isn't going away. And certainly if you look at what the ADA did, in providing a tremendous amount of funding towards Q2, there's obviously a lot of passion behind that particular endeavor.
But today we're talking about evidence-based dentistry.
That's right.
And issues with evidence-based dentistry, and how to determine that maybe there are some unintended outcomes of evidence-based dentistry.
So
let's talk. Go ahead, Jeff.
No. I was going to say that, it's interesting because as practitioners, you get out, you practice for a while, and everybody kind of has to find their footing of, how do we substantiate the decisions that we're making in practice? And, this is what I'm doing, but am I doing it just because I was told to do it in dental school? Am I doing it because I've seen it work before? Am I doing it because someone else told me it worked? Or am I doing it because that's what the literature truly supports? And I learned this at the Coy Center, really is where I became more of an evidence-based dentist. And it became a very important thing to me. But what I also found was that many times that a lot of dentists who claim to be evidence-based may not truly be looking at the right evidence. And when I say the right evidence, I mean the higher level studies, the randomized controls, the meta-analyses, and then maybe they haven't looked at the biases. Maybe they didn't really look at the protocols and the methodology of the study. And so it's always been kind of a point for me to try to figure out, how did they come to this conclusion? But yet what we hear in literature reviews are typically a summary of all these conclusions, and we really don't know how much weight to put into all those studies. So as a clinician, that was my experience. What is your experience with evidence-based dentistry? What got you interested, and where has it taken you?
Right. Well, the first hint that I had of evidence-based dentistry was in 2005. An epidemiologist at Tufts, and even though I never met him, we were probably in rooms together at the same time, and his name is John Ioannidis. He published an article about why most published studies are false. And he had a half dozen reasons that most published studies are false, which if I was giving an hour-long lecture, I would go into. But that was 2005. 2016, he doubled down on that. And now it's alert. Industry has taken over evidence-based medicine, and here's why. And that's the thing that I like to talk about. I like to talk about how industry tries to worm in and make changes in evidence or direct evidence or mold evidence to fit their story. But is it okay if I share a slide quickly?
Yeah, can you from your screen?
Actually, it looks like I can.
Okay, go for it. I'd love for you to.
Okay,
Please.
got it. All right. So can you see the slide that I'm looking at now? Yes, I think so.
There we go.
Okay,
There you
great.
go.
So evidence-based medicine, evidence-based dentistry is actually the confluence of three ideas. One is the evidence, and it's important that we find the right evidence and that we find evidence that we trust. And as a provider, your clinical expertise. So it's not only the evidence, it's also clinical expertise, and it's patients' needs and preferences also. So let me give you just a quick example to tell you how this works. Let's say you have a patient who has gastric reflux disease, and they need a two-surface restoration. We know that there's a lot of evidence out there that a two-surface amalgam will last longer in the mouth of a patient that has gastric reflux disease because the ions in the metal are able to counteract the ions in the acid that are weakening the hard tissue. But what is your clinical expertise? Are you a dentist who is able to place a quality two-surface amalgam, or are you from a school where you weren't trained to do two-surface amalgams, or where you didn't have a lot of experience, or have you not done a two-surface amalgam in a long time? And then let's think about the patient's needs and preferences. Your patient may say, "Hey, I don't want that silver mercury thing in my mouth." And by the way, I'm actually a little bit pro amalgam. So when I say that, I'm definitely not against using amalgams. But your patient may say, "I don't want that thing in my mouth. I want something that looks more like my tooth." And so that's their preference. But yet they have gastric reflux. So now we're going to have to go back to the evidence and say, okay, here's a patient who has gastric reflux. They will not let me put anything metal in their mouth. What type of tooth-colored restoration can I put there? So this is how evidence-based dentistry is supposed to work. Okay.
Now, I would say that right there, to me, when I look at that nowadays, I get exactly what you're saying, and I appreciate it. Don't take this the wrong way, but
Sure.
like one of the things that first pops in my mind is that really hones in with AI. What you're showing right there. I mean, you know, you've got to take all those three things into consideration, and I think that's a misperception of AI. And I know that's not what we're talking about, but when I'm looking at this, I'm like, that's the first thing that pops in my mind, and I totally get what you're saying, and I appreciate it. So, love it.
All right. Now, let me just put up another slide here. Now, especially now that I know how your program works.
Go for it.
Okay. Come on.
There you go. I have to add it to the stream. Sorry,
Oh,
buddy.
okay. All right.
Yeah. Just it should be there. Let me try it again. It says it's showing. Click it one more time on your end. There we go.
It is.
Okay,
Sorry.
great. All right. So this is the evidence pyramid. And Jeff, you probably saw this evidence pyramid when you studied, or one similar to it, when you studied evidence-based dentistry. So on the evidence pyramid, ideally, the evidence that has the least bias is at the top of the pyramid. And this would be, I'm sorry that it's so small that it's hard to read, but evidence summaries of topics, clinical practice guidelines, and then right underneath that, meta-analyses and systematic reviews. And meta-analyses are basically where you take data from multiple studies, put it all together in a particular way. And then instead of having a study with 20 people and a study with 50 and a study with 100, you have a study with 170 people, which is probably closer to the truth than the smaller summaries. But what I see many times is that the industry is able to control the questions that are asked in these systematic reviews, meta-analyses, in the clinical practice guidelines, and they control it by providing the funds to do these studies, to do this research, or by having researchers that are in their employ do this research and then publish it. And there are actually several other techniques that they can use besides just using money. And this is really the fun lecture that I like to give, going over step by step all the different ways that that industry can direct the research by funding, by questions, by even doing things like, we want to compare our product to a product that is just not a very good product. We don't want to compare our product to the best product. We want to compare it to one that's not very good so that we can show that our product is better.
Or we take the best results that show our product in the best light.
Exactly.
From the internal data that we have. Mm-hmm. So, in what you're saying, I think that by and large, our profession is more trend-based than evidence-based. And so how do we shift? How do we make that shift?
Well,
everybody needs to go to your lecture because you're the leader.
A lot of that is happening in our schools. So first of all, I was the chairman of the Evidence-Based Dentistry Special Interest Group at the American Dental Education Association. It's a very active group with a lot of members representing all of the dental schools. This is being taught in every school now. It was not being taught in every school 10 years ago. So it's building. And as some of us get older and we hire younger dentists to come in to work in our practices, they're going to know these techniques of evaluating these papers to see which are the papers that we can trust. Also, there's a book. I hate to hawk a book that I worked on, but let's see. I'll just show it quickly. This is published by the American Dental Association. And let's see. Yep, there it is. How to use evidence-based dentistry practices to improve your clinical decision-making. So this is available from the American Dental Association bookstore. We published this just a couple of years ago. I'm one of like 100 authors that worked on this. I worked on the chapter about how to teach evidence-based dentistry.
So I'm glad to hear that the universities are bringing in the program, but the elephant in the room to me, having gone to a university that also received a tremendous number of grants and support from outside institutions,
Absolutely.
How do universities even become unbiased in the scientific information that they're providing to their students? And also, they obviously are running their own research programs and their own research that they're doing on different products and techniques, et cetera. How do you ensure that those programs aren't biased by nature?
That's extremely hard. And I am an associate professor working full-time at a university. So, and I am not in the research department. So I don't want to speak for them, but I have seen many instances at our university where the school has been approached with promises of large sums of money from from different companies to do research for them where that money was turned down. The school can accept money from the outside, but there needs to be an understanding that there is a separation between providing money to the school and control over a research outcome and control over publication of an outcome, because that's another way that that industry can control what we learn. There's a lot of gray literature out there, literature where research has been done, where it's been completed, where papers have been written, and then they're not published because the researcher has an agreement with someone in industry or with a particular company not to publish without the company's permission.
I think, in essence, you need rebels at the school that are willing to kind of buck the trend and perform their own independent studies. And, I would say that one of the rebels that's out there actually happens to be from your school, Jennifer. I was presenting on cements last year and bonding techniques, and Dr. Suleiman, he loved what I presented, but he was telling some of the manufacturers that were there that if I can get the same results in my lab, then I will talk about your bonding agent and your cements. And I think that unfortunately there's very few of those out there, and that really resonated with me. I wish we had more of those that were a little bit rebellious when it came to that, and that that really went out there and researched the products on their own to show how they work in a truly independent setting.
Right. Now, there is another way that we can give people more independence. I'm going to throw up another slide.
While you put that up, Dave, do you find that the influence of outside funding and biases is the same across all medical disciplines? Is it worse in optometry or veterinary medicine or general medicine? Is it worse in dental medicine? Like, does there seem to be?
I can't say if it's worse in one versus another. By the way, I'm not getting the slide to come up, but I have it
here. Hold on, I got you. I got you
okay.
covered. We're gonna try it again. Try it one more time. It's showing.
Yeah.
Damn technology.
Can you see it?
I can see it. For some reason, it's not adding to the stream.
He has to click again on it.
I'm clicking.
Well, we'll wait just a second.
Okay.
Keep talking. It'll show up.
So the slide that I'm trying to show you is it's the results of a study where, it's the results of a study where researchers looked at research that was funded by the NIH compared to industry-funded research and what the outcomes were. So if they're looking at research across medicine, and they have 226 NIH-funded studies compared to 226 industry-funded studies, what they find is that in the NIH studies, almost 21% of the studies are favorable for the product that they're testing. If you look at industry-funded studies, nearly 51% are favorable for the product that's being tested. By the way, I do have a citation on this.
There you go.
That's
you can go back. Yeah.
Okay. Now you can see it. Great. So you know what? First, let me give you the citation. It's right here. It's Haris Riaz, Sajad Raja, a few other names here that are more difficult for me to pronounce, sorry. Impact of funding source on clinical trial results, including cardiovascular outcome trials in the American Journal of Cardiology. And this is December 2015. By the way, if I sent you a list of all of my citations.
We'll make
Thank
sure they
you.
get published.
Thank you. So favorable outcomes over medicine for 226 random NIH-funded studies, 20% were in favor of the product being studied. Industry-funded, almost 51% were favorable for the product being studied. If you look at cardiology only, and that brought us down to 25 NIH studies and 215 industry-sponsored studies. Out of 25 NIH-sponsored studies, only 3 studies, 12%, were favorable for the product being studied, whereas in industry-sponsored studies just for cardiology, 109 of 215 studies, or 50.7%. So it's not just dentistry, it's different areas of medicine. Industry has developed ways over time of inserting their influence in a variety of ways, and even in if you're looking at guidelines. So guidelines are supposed to be the highest level of evidence, the level of evidence that and I've been involved in writing guidelines. I'm one of the authors of one of the lead authors of the Massachusetts Oral Health Guidelines for Pregnancy and Early Childhood, which would be another fun talk.
Mm-hmm.
So another study is let's see, here we go.
Dave, I've got can I interject for one
Absolutely.
second about that with reference to guidelines? Because I've been involved in several groups in organized dentistry, and I think guidelines may be one of the places that I have felt the most let down, because very often the committees that are chosen to write these guidelines are of similar mindset and come from the same pools of dentists. And I can speak to, several groups that I'm in. I don't want to mention any names because I don't want this to become in any way political, right. But there's one particular group that I'm very involved with. And for years we had internal battles because there was really a bias, not even towards a certain treatment protocol, but towards a group that excuse me, a group that promoted a certain treatment protocol. And so within the guidelines, I found biases towards eliminating anything that had to do with that treatment protocol, even though there was nothing that suggested that it wouldn't lead to better outcomes. And so I guess that's my, even guidelines are subject to the biases of the committees that are selected to present those guidelines. So how do you get around that?
Right. Well, in another paper where they looked at the guidelines committees for the 20 most common cancers, and one thing that they recommended, good. Okay. So so they looked at the guidelines committees for the 20 most common cancers. They looked at 54 members of the committees and compared them to people who were not members of the committees, all medical oncologists. So 2 medical oncologists who are not on the committee compared to 1 that is on the committee, and compared payments that all of these physicians received from industry, and found that on average, members of committees were paid $11,000 if they were on the committee, compared to $3,000 if they were not. And you can see by the p-value, p of 0.02, that this is statistically significant. And the recommendation of these authors, and this was published in Oncologist in 2021, the recommendations of these authors is that medical oncologists on guideline committees had more ties to industry. So we need to reduce potential conflict by choosing committee members with less conflict of interest.
I promise I did not know you were going to put this slide up.
That's pretty awesome, Jeff.
Yeah.
That's pretty awesome, Jeff.
I had no idea, but
well, I put this slide up in response to what you were saying.
Okay.
Yeah, and so I'm listening too, and then also this paper, they look at who wrote the guidelines. The paper's called Conflicts of Interest and the Quality of Recommendations in Clinical Guidelines. And they looked at the American Psychiatric Association's practice guideline for the treatment of patients with major depressive disorder. And what they found was that there were 6 members of this particular guideline committee. All of them had relationships with industry, an average of 20 relationships each, and 9.1% of the research they cited. So when you're developing a guideline, you're supposed to do a scoping review and get all of the research on your subject. 9.1% of all the research they cited was written by those 6 doctors. And 13% of the references that they use. So 9% of the cited research and 13% of the references were from those same 6 doctors on the guideline committee. A third of the studies that they looked at didn't even look at outpatients with major depressive disorder, which is what the guidelines question was. So, and then when I give the lecture on this, and I'm not going to do this now, but I go into this whole long business about how pharma actually developed the whole idea of type 2 diabetes because they were trying to develop medications to treat type 1 diabetes and found, well, this medication doesn't work on type 1 diabetes, but it does control your blood sugar.
Interesting.
So yeah, this is a wonderful paper by Hunt et al., published in 2021, so a very recent paper, and it's published in the Journal of Bioethical Inquiry, and you have that citation also. That's a very interesting paper. It's a little, you have to be a little bit of a long hair to understand it.
That's actually really... That's interesting. I'm going to have to look into that one because that's such a popular condition in today's society.
Oh, yeah. 1 out of 3 Americans. We go from, in the 50s, 1% of Americans were diagnosed with diabetes. Now it's 1 out of 3. Really? And it's $800 billion a year industry.
So since we're on this topic, I'll just go ahead and ask because I'm hoping you've done a little research. What have you found on Ozempic?
I haven't even looked at that yet, and someone close to me is using it, so I think I might just,
that's kind of my that's my next topic to just start looking into because I'm really interested to see where this is headed with everything that's going on with that right now.
Well, something that I think is interesting about Ozempic is it's a medication that if you start using it, apparently you have to continue using it forever.
Yes.
And that's the golden goose for pharma.
Yeah. Well, it's the golden goose for pharma, and it's to the detriment of a lot of the people that are using it as a trend or whatnot. And I think there's going to be some long-term complications. So I'm really interested to see what you're finding.
Well, I'm hoping that it's going to be, I hope that the use of Ozempic is not going to be harmful for all the people that are using it for weight loss.
I agree.
And I know that that being heavy it puts a lot of stress on your body.
Of course.
And when we weigh risks and benefits, hopefully the benefits of Ozempic outweigh the risks.
Yeah. Yeah.
So, go ahead,
I
I'm sorry, let you finish.
Well, I was just going to say this conversation today is really pretty interesting to me. I have a patient that came in. My daughter's got ulcerative colitis, and so does Jeff's son. And so we've been talking about this a lot lately. So I had a patient that came in today that had Crohn's disease, which is just, similar disease, different location. And he was a very smart guy. You could tell just by talking to him. And he mentioned, as we were looking at him, that he had Crohn's disease. I said, oh, okay. I said, well, are you undergoing infusions, or what are you doing to manage your Crohn's? And he says, I'm not doing anything. And I said, really? And he says, yeah. He goes, I found some research several years ago, and I finally found a doctor to prescribe it to me, and they were using naltrexone in micro dosages. And he goes, I did it for 6 to 8 months, and I've been in remission ever since.
Wow.
And so I asked today, I mean, this whole conversation is so important today, because I asked him, I said, would you do me a favor? Because my wife is a nurse. She's very, very in tune with the research. She's very in tune with my daughter's condition. And I came home today and I was like, hey, we need to look into this. I was like, this is something we definitely need to look into. And she's like, oh, I'm already looking into it. And I was like, well, this guy's got a ton of research on it. He brought it to his doctor, got his doctor to prescribe it. And I said, he's going to send me all the research he has. So, I mean, I think that it can be beneficial, but I wonder why that information, if it's working and there's a lot of research surrounding it, why it's been suppressed from the masses that have Crohn's and, various GI autoimmune diseases that attack the GI system. And I can't help but think it's because of some of the biases that are out there and some of the corporate pharmaceutical sponsorships that are out there.
Right. So perhaps we have to follow the money.
Yeah.
That's what I'm thinking.
Yeah, I mean, I would piggyback on that and say that there were, even during COVID, and I certainly don't want this to go in a political direction, but that even during COVID, that there were several there were several therapeutics that had shown clinical evidence to be successful in certain populations, but yet a lot of those studies were suppressed, or the efforts, instead of allowing all the science to come to the front and then debating the validity of the science all around, a lot of times the science from one side is suppressed, which is not fair, because where we move ahead in medicine, I've always felt like, is when we actually sit in a room and look at all the science and debate it as unique individuals with different perspectives.
I see a message from a Facebook user. Dr. Stephen Novella was the keynote speaker at the ADA's Evidence-Based Champions Conference a while back and had mentioned the term p-hacking. This is another thing that John Ioannidis discusses, although he doesn't call it p-hacking, but he discusses that concept in his papers.
That sounds like a bathroom violation.
Yeah. Do you mention what p-hacking refers to?
Well, it's adjusting your study in such a way that your results end up being statistically significant, and whether or not it's actually clinically significant.
Interesting.
So, as we get close to time here, as a practitioner who struggles every day with what's good for my patients, what actually is effective treatment, what's going to work in this particular clinical outcome, and I do reference evidence-based that I've read and that I learned in university and et cetera, when helping patients to make decisions. And yet I can't help but find at times that I fear that I've been influenced, and I was unaware of my own influence, like that that I've been affected and I think a certain way in error. And I think would love to get your, closing remarks on guidance for practitioners who are out there who, in all fairness, cannot consume all of the data, that they do not have the bandwidth to be reading journal articles and then to spend the exhaustive efforts to discern what is good and what is bad and et cetera. What do they do in the trenches every day to make sure they're still operating with guided wisdom?
Right. So I'm going to mention a particular website. Let me just look up the, let me see. It's called the Dental Elf, which I know sounds really funny, but it's the Dental Elf, National Elf, or the National Elf Service is a bunch of people who are trained similar to me, and they publish very short, bite-sized, not more than 900-word summaries of systematic reviews and meta-analyses. Here, I have a screen up with the Dental Elf on it. Let's say. So it's nationalelfservice.net/dentistry. And so here's one: photobiomodulation for postoperative pain, swelling, and trismus after third molar surgery. Review the effects of So this is, someone has, and you can read the full story. Someone who's trained has looked at a study of this type of treatment to treat pain and swelling after third molar surgery. They talk about how the study, a little bit about the background of the study, the methods of how this review, so this is a systematic review, so a little bit about the methods of how the review was done, what the results of the review are. They found 33 studies involving 1,347 patients, and 30 studies were considered to be at high risk of bias and 3 to have some concerns, and 23 studies contributed to the meta-analysis. So these are high bias studies. And then they give you the evidence in these charts. And then here's the author's conclusion. The evidence of the effect of PBM regarding the control of pain, edema, and trismus following third molar extractions is low or very low. And then here's the comments of the person who wrote this summary. This type of summary is called a critical summary of a systematic review. So it summarizes what could be a 100-page long review and then critiques it and tells us dentists what our takeaway should be. There are also critical summaries like this on the ADA website. There are critical summaries published in JADA. I published 4 of them in JADA. I published one of them in this Dental Elf review, or Dental Elf system. And so for a dentist who doesn't have the training to evaluate a systematic review, this is supposed to be written in a way that any dentist can understand it.
So,
and
Dave,
yes.
we're just about out of time,
Yes.
and because we absolutely have to have you back, because the nerds like me find this, I just love this stuff and eat this up. But isn't that subject to the inherent bias of the person reviewing the meta-analysis, which is supposed to be the highest level of evidence, and then you're taking it down to the inherent biases of one individual? That
Right.
and it doesn't matter, who you are. We all have inherent biases.
Oh, sure. But the person who's writing this review, they have training to spot biases that are
Right.
in the paper that they're writing. And then the editors will go over this and do their best to make.
So they have a background checker as well.
Right.
Okay.
Right. I couldn't just write a critical summary like this and expect that it's. And as a matter of fact, the first time I wrote a critical summary, I went back and forth first between me and another author so many times, and then between me and the editors several times before I had it worded in a way that they felt was reflected the least of my bias possible.
Awesome. Well, Jennifer, great guest. I think you should close us out tonight.
Well, we're always looking to bring on individuals who open our eyes to what's going on in dentistry, but also hopefully open up the eyes and ears of our listeners to just wake up every day trying to be the better clinician that we all, I think, strive to be. So, Dave, thanks so much for joining us, for accepting my creepy
We appreciate
DM on Facebook and agreeing to participate in this open dialogue. There's so much more to unpack here. So hopefully we have future opportunities to do so. Thanks so much for tuning in tonight. Guys, football was on this week. That means fall is coming. Pumpkin spice lattes.
No,
if you're
I knew you were going to say that.
If you're into drinking out of gourds, they're on their way. The leaves are going to be turning. The weather will be cooling down in the south, maybe eventually. But either way, I sense a change in the tides. And with that, have a great night, guys.
Thanks,
Have
everybody.
a good night, everyone. Thank you.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.